Before we start, we wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home of many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. The Temerty Centre for AI Research in Education and Medicine at the University of Toronto has been made possible by the generous donation of the Temerty family. We're very honored to have our newest alumni who have recently received honorary degrees from the University of Toronto, Mr. and Mrs. Temerty, who are here in the audience today, with us to personally thank them for their transformational gift to the Faculty of Medicine, now the Temerty Faculty of Medicine. It's their generous gift that's actually enabled the creation of T-CAIREM and so many of our initiatives like today's event. T-CAIREM is an interdepartmental center that serves as a catalyst for healthcare of the future. Our community consists of healthcare providers, trainees, researchers, educators, computer scientists, engineers, and industry. Our goal really is to transform health through AI. And we really fundamentally believe this is a team sport. So you're going to see people from all across different disciplines coming together, really trying to drive the future of medicine and the care that we deliver to our patients. I want to introduce André Picard. We're very, very fortunate to have him here today. He is an icon in the media community. He is the health columnist at the Globe and Mail, the author of 6 best-selling books. He has received much acclaim for his writing, including Canada's top newspaper prize, the Michener Award for Meritorious Public Service Journalism. He's also received the Owen Adams Prize, which is the highest award given to a non-physician by the Canadian Medical Association. André is a graduate of the University of Ottawa and Carleton University, and has received honorary doctorates from 8 universities, including the U of T and UBC. And just last week, he was awarded another honorary degree from the University of Ottawa. So we're delighted to have André come and present to us. Thank you, André, and I'll ask you to come to the podium. Thank you.
So thanks. I want to start also by thanking the Temerty family for attending and for your really generous philanthropy, your steadfast commitment to medical education, improving healthcare, science communication, and Canada more generally. It's very impressive what you do. So thank you, and I'm flattered that you're here. As you've heard in the introduction, I think it was mentioned, I've been involved in many Temerty talks, most of them online, and they're really wonderful events. They're really fun for me because I learn a lot of stuff and meet a lot of people, and it's nice to do one in person. Now, when I do the panels, I usually am interviewing a bunch of really smart people, and today, unfortunately, you're stuck just with me. So I want you to temper your expectations a bit, and I'll see what I can do to keep it semi-interesting. So, as you see, my topic is about Medicare. That's what I write about. I write about health policy. So Medicare was born just after the Second World War, during the baby boom, not coincidentally, and during an era of extraordinary technological advances. Will it be reborn during the next technological revolution, which we're on the cusp of? That's what we'll see. And I hope to be around for a while to figure that out. So in 2050, the youngest boomer will be 85 years old. I'll be a spry 90. I hope I'll still be hunched over a keyboard, or maybe dictating my ideas to an AI bot, or maybe my brain will be replaced by a microchip. I don't know. We'll see what's coming. Just over a year ago, for the first time in history, Canada became home to more people over the age of 65 than under the age of 15. We live in a very different society than ever in history. By 2050, there'll be 50% more seniors than children. You can imagine what that does to society. The hope is that technologies like AI will help close the yawning gap between demand and supply for labor, particularly in healthcare. And that's already begun. Imagine what it's going to be like in 25 years. We're already at a point where for every graduate, there are 2 retirees in healthcare. So that doesn't bode well on the labor market, unless you're looking for a job, which I see a lot of you young people will be, so that's great. So that's what I want to talk about. I want to talk about the past, the present, and the future of Canada's health system. The first two, the past and present, are pretty well documented. Nevertheless, I like talking about them because I've found that in my travels around the country that while Canadians think really highly of Medicare, they don't really know much about it. There's a lot of mythology more than there is reality in their thinking. The future is a little bit more difficult to talk about because it requires some crystal ball gazing, a lot of guesswork. As the legendary American philosopher Yogi Berra said, I don't like making predictions, especially about the future. And I'm going to do so anyhow, but cautiously. And I'm going to tell you up front that I'm not going to say a lot about AI. We can save that for the question period. You guys are experts on AI, and I'm not. So I'm not going to pontificate on the singularity or whether we're moving from the digital to the quantum age or any of that stuff. I may be a journalist, but I'm not a complete fool, so I'm not going to try to tell experts what they already know and I don't. But we'll wade into AI a little later. I want to mention too that if you haven't figured it out by this point, I don't have a PowerPoint. I don't have any bells or whistles or anything like that. We're already having a heart failure there. The organizers have warned me that, this can cause some stress to academics, so we do have an external defibrillator nearby if need be, but I personally am allergic to PowerPoint, so we have to avoid.
That's wrong thing that outbreak. Wrong diagnosis, wrong treatment.
Okay. Oh, well. Okay, well, see, I'm not a doctor. I can do wrong diagnosis. So let me start with some history. I'm a big history buff, medical history buff, and the history of Medicare is quite interesting. Of course, it didn't fall fully formed from the sky. The principles of Medicare were not carved in stone tablets by the hand of God and handed down to Tommy Douglas. Some people kind of think that, but that's not the case. Medicare is essentially just a public insurance program. It's nothing more, it's nothing less. When people say things like Medicare is what defines us as Canadians, I kind of bristle at that. Personally, I don't want to be defined by an insurance program, not a medical one, not a house insurance, not car insurance. These are practical things that we should use. They don't define us. What matters most are the services that this program provides, the values that underlie Medicare, not the program itself. We shouldn't hesitate at all to fiddle with it. And I'll talk about those things a little bit later. But I'm going to focus on history for a bit. So Canada's health system, like every health system around the world, developed over time. It was shaped by culture, history, politics. Every system is different. They all have their quirks. Canada's a little quirkier than most. Our first hospital, Hôtel Dieu de Québec, was founded in 1639 by Augustine friars. Hôtel Dieu de Montréal was formed 2 years later by the Sisters of St. Joseph. I lived in Montreal for a long time, just steps away from Hôtel Dieu. Hospitals were essentially places where people went to die. The most effective treatment was prayer. And there's some days when I'm writing my column that I think we've come full circle, that, we're back to the point where the best thing we have is prayer in our health system, especially when you're waiting 48 hours in the ER, for example. Now, for about 300 years, religious institutions, and Catholic nuns in particular, dominated the delivery of care in Canada. We have other religious institutions as well. Every city has a Mount Sinai, a Grace Hospital for the Salvation Army. I personally was born in a Grace Hospital. My mother said, we got you at Sally Ann, we can always send you back. So I had to behave. Now, public funding of hospitals, was charitable for a long time. It only really began in earnest public funding after the Second World War, as I mentioned earlier. But faith-based institutions are still major players today. I guarantee that every city in Canada has a Saint something hospital. The strong association between religion and healthcare has had some lasting impacts. And I think the main one, the most important one, is that Canadians have this deeply held cultural belief that healthcare should be free. We see healthcare almost as an act of charity or a government program, not a business transaction. And this is very different from most of the world, and it shapes our approach to healthcare. We also see medical care as a vocation, as it was for nuns and friars for many centuries. We see it as a vocation as much as a job. And I think this helps explain as well why we tend to exploit our workers. We treat our health workers, again, a lot worse than other countries. And I think there's a historical reason for this. And it's also a reason why our health facilities are very austere. There's not a lot of art, or they're not beautiful. You know, when I go to places like Spain, the hospitals are beautiful. And there's nothing wrong with that. It actually helps the healing. But we're very, very cautious about that. Now, the other institution that profoundly shaped Canadian Medicare was the military. The first state-funded health insurance program in Canada was created for veterans of the First World War and their widows. And this continued. We continued to take good care of our soldiers throughout the Second World War. And that accelerated talk of universal health care. People started saying, you know, if it's good enough for soldiers, why not good enough for our children and for us? So the talk of public health care grew. Now, everyone knows Tommy Douglas, who's voted the greatest Canadian of all times in a CBC poll. He got the ball rolling. His CCF government in Saskatchewan created the first public health insurance program in 1946. Now, what we often forget is that in neighboring Alberta at the same time, Premier Ernest Manning took a different approach. He offered to subsidize private insurance for the poor, for the blind, and single mothers. He said health insurance should be left to the employers of workers. And that debate about which of these approaches is best, it actually continues to this day. Should be entirely private, partially public. And as you will hear later, we have a bit of both in Canada. We're not sure what we think of either model. And so do most countries in the world, most Western countries. Medicare, as we know it today, was shaped between 1957 and 1966. In that period, public hospital insurance was extended to physician services, and the federal government agreed to cover half the costs. And that created a semblance of a national program. And to this day, that's what Medicare covers. It covers hospital and physician services. We call these medically necessary services in our law, and that's a very important term, but a very vague one. The last province to sign on to the federal funding deal was Quebec in 1972. So it took 25 years for us to have a semblance of a national Medicare program. And this is, I bring this up because it's a reminder that in Canada, we're very, very slow to change policy. And I think you have to bear this in mind when we talk later about technology. We're so slow to change. How are we going to adapt to this rapidly changing world? Now, the medically necessary language that I mentioned a moment ago, it was enshrined in law, but not until 1984. That law features what we've come to call the 5 principles of Medicare: universality, portability, accessibility, comprehensiveness, and public administration. Write those down because there's going to be a test after, but everyone should know those 5 so-called principles. Now, over the years, the Canada Health Act has really been elevated to the status of a quasi-religious document. Everybody will say, oh, you can't do that. Canada Health Act doesn't allow it. In reality, the Canada Health Act doesn't ban anything. All it says is that if a province violates one of those 5 conditions, Ottawa can theoretically withhold the transfer of some money. So it's actually a very weak bit of law, but it's nicely written. Sadly, the Canada Health Act is violated every single day. We have very little portability in this country. If you try to get healthcare in Ontario with your Quebec health card, they send you packing. Comprehensiveness, dubious. Universality, not so much. So this law is nice on paper, but it's really a paper tiger. It's become this mythological creature, though, that everyone cites. So we can't do this, we can't do that because of the CHA. Now, forgive me for going on for so long about history, but I think it really is important. The lesson to retain from this is that we have a state-funded and state-run health system whose basic structure hasn't changed in 6 decades or more. Meanwhile, the world, from medicine to demographics, has changed a lot. So have the needs and the wants of patients. So in 1957, when Medicare was born, Canada was a young country. The average age was 27. Life expectancy was 67, if you can believe that. That's why as an aside, we created pensions at that time. You wonder why we have this arbitrary age of 65 for retirement. It's because the expectation was most people would be dead before they collected money, because most people died by 67. So it's actually a good, smart program. Hasn't really adjusted. It's gotten a little more expensive over time. And at the time, back in the 50s, what a health system delivered was mostly acute care for traumatic injuries, physical problems, and childbirth, of course. At the time, people were making babies, lots of babies. They're also smoking a lot, dying of heart attacks, and they were working on the farm and suffering traumatic injury. So that's what the system was built for. It was a good idea. It's what you should do. It was appropriate. Now today, Canada is a different place. The average age in this country is 47. Often I speak to healthcare professionals and I say, oh, everyone's under the age of 47, and they laugh, but you guys actually are all under the age of 47, so it's interesting. Life expectancy is 82, and that really understates it, because if you live to 65 today in Canada, you can expect to live more than 25 years on average. So 90 is sort of the normal now, if you get past the early years. The vast majority of our care is not acute anymore, it's chronic care, very different needs. Baby making, we're not into that so much anymore. Today, the overarching health needs are housing, elder care, which is largely the management of multiple chronic conditions as people age. So the baby boomers have come of age, but the health system hasn't grown up with them. It's still stuck in the 50s. It hasn't adapted to their needs, and that explains a lot of our problems. I think what's wrong with Canadian healthcare today, in a nutshell, is that we're trying to deliver 21st century care with this 1950s model of delivery and funding. We have an EDSO, but we need an EV, and we just haven't made that leap, and it's getting more urgent. So let's talk about, that's the past. Let's talk about today for a bit. To date, I haven't mentioned the elephant in the room. Mohammed mentioned it, COVID-19. Now, I want to say that the pandemic didn't break Canadian healthcare. Some people say it did, but it didn't. It was already broken. What COVID-19 did was brutally expose the weaknesses in the system that were already there. The cracks that existed became chasms. You see this in the news headlines every day. 1 in 5 Canadians don't have a family doctor. The chances of getting one are now slim to nil. ERs are closing with increasing frequency. When they are open, they're overflowing. People are being triaged in parking lots. It can take 8 hours to get an ambulance if you fall and break your hip. It can take months, sometimes years, to get a referral to a specialist. Never mind the longer wait for surgery. Drug shortages are routine. Approval of new drugs takes forever. Doctors are burning out and closing their practices. Nurses are leaving in droves. Personal support workers are jumping at the opportunity for better work at Tim Hortons, which has better pay and benefits. Aging at home is becoming increasingly difficult because we don't have any home care to offer. We don't have any supportive housing to speak of. We're kicking people out of hospital and sending them to nursing homes against their will, particularly in this province. Long-term care homes have become killing fields. During the pandemic, Canada has seen more than 50,000 deaths, but half of those occurred in long-term care homes, where only 1% of the population lives. It's a massacre of neglect. I wrote a book about this during COVID. If that weren't bad enough, as access to care diminishes, costs are soaring. Not a good combo. Meanwhile, technology is progressing at a mind-blowing pace. Artificial intelligence, robotics, deep learning, you name it. But we in Canada still use fax machines as our principal means of communication in healthcare. And that's not a joke, sadly, it's true. The headlines are pretty depressing. Increasingly, our experiences within the healthcare system are frightening. Now, don't get me wrong. We do have good medical care in Canada. If you're in the right place at the right time, you get fabulous care. But we have serious access problems. Have trouble moving between different parts of the siloed system. And a lot of that care is delivered not because of the system, but in spite of it. Workers have workarounds to everything, to the rules that don't make sense. But those workarounds are just not working anymore because there's too much to skirt. So how do we drag Medicare kicking and screaming into the 21st century? Now, this is something I've been writing about for decades. And my message has always been pretty simple. The problems we have are largely systemic. So what do we have to do? We have to fix the damn system. That's the starting point. Now, of course, that's easier said than done. And I'm not suggesting that we just need a fancy flow chart and everything will be solved. It's not that simple. We have to address the culture as well, etc. But we have to create a system that allows our health workers to care. And they have trouble doing that now. Now, the good news when we talk about reform is we know exactly what to do. If there's one thing Canada does better than any country in the world, it's study the shortcomings of our health system. We do it over and over again. Since the advent of Medicare, there have been dozens upon dozens of high-level government-sponsored reports written about reforming Medicare. Every one of those reports features a long list of smart recommendations, and most of them have not been acted on. The principal problem we have is not lack of solutions, we have an implementation crisis. More specifically, we have this lack of openness to change. We're stuck in our ways. Now, we in the media write about the horror stories. The patient who waits 72 hours in a hallway, the rape victim who's turned away from hospital for lack of nurses, the couple married 60 years and separated in the nursing home by bureaucratic rules, the town without the doctor, the baby denied a life-saving drug, and on and on. But there are many ERs in Canada with reasonable waits. There are towns successfully recruiting doctors. There are magnet hospitals where they never have trouble recruiting nurses. There are health clinics that are having dramatic impacts on their communities by doing medicine differently. We have great long-term care homes where couples live together and well. We have health teams reinventing how medicine's delivered. We have hospitals that are using AI today. They're at the cutting edge, like your own. What we need to do is start by scaling up all these successes. We have to stop perpetuating the failures. That will get us a long way very quickly if we do it. Every problem we have in Canadian healthcare is structural and administrative in nature. We have to get out of the way, get rid of some of the red tape. It's not a problem of technology or of medicine or lack of money. We have all those things, but we don't have a good attitude. We're reluctant to fix things. Now, a few years back, I wrote a book about the history of reform, or actually it was about the lack of reform. And as part of that research, I read all those reports I alluded to, dozens and dozens of them. And somewhere along this painful journey, I had an epiphany. I realized that all these reports, the Romano report, the Clare report, the Mazankowski, they're all named after some old white guy. All of them said the same thing. So I took all their recommendations and I put them into an Excel spreadsheet. And then I realized that, there's really only a handful of things that need to be done because they're all saying the same things in a variety of language. And what's interesting is they all say the same regardless of the political background. With Conservative government, NDP, Liberal, all their appointees have the same conclusions. So I boiled it down to 5 key areas that we have to address. Number 1, primary care. The foundation of every health system is primary care. The best health systems in the world have the best family doctors. That's the starting point. But in Canada, that's actually the weakest part of our system. We have 6.5 million Canadians who don't even have a family doctor. If you build on a shaky foundation, everything else risks crumbling. And that's what we're seeing today in the real world. We're seeing our Medicare system crumble before our eyes. And it's largely because of that. In an aging society, we need to move away from an acute episodic care model to a chronic care model. We need workers to work in teams. We need every Canadian to have a medical home where someone is ultimately responsible for their care and their navigation through the system. All the technology and all the money in the world will fix nothing if people don't have the basics. Number 2, community care. Every report for 60 years has said this. We need to treat people where they live in the community, not exclusively in warehouse-style institutions like hospitals and nursing homes. Now, I'm not saying we don't need hospitals or care homes. Of course we do, for some people. But they need to be the last resort. And everything should be about keeping people out of hospital and out of care homes and keeping them in the community. Number 3, drugs. We need to extend universal health coverage to prescription drugs. And we've been chattering about this politically for 6 decades, but with little progress. Now here I'm careful to say that universal doesn't mean everything is covered publicly. Universal means everyone gets access to essential care. Doesn't matter the delivery method, private, public, doesn't matter, as long as people get the care they need. And this one is becoming more urgent because of technology. The formularies that we have now that say yes or no, your drug's covered, that's not going to cut it in the era of immunotherapy and personalized medicine. It's getting much more complex to provide drugs and to fund them. Number 4, all these reports have talked about the importance of the social determinants of health, the need to invest in prevention, particularly for socially disadvantaged and marginalized groups like our Indigenous peoples. But above all, we have to stop pretending that health is merely a medical issue. 95% of health funding in Canada goes for sickness care, only 5% to prevention. What really matters to our health is having a decent income, a roof over our heads, a good education, healthy food, a healthy environment, social connections. Those things all matter much more than medicine, which tries to patch you together when you're sick. And number 5, all these reports have talked about the importance of people, human resources. Health should be a hands-on, people-centered business. Labor accounts for about 2/3 of all our health spending. But we have to make sure we have the right mix of health workers, a good work environment, teamwork. Staffing is without a doubt the number one challenge in healthcare today, not only in Canada, but around the world. We have to do better at recruitment, but mostly at retention. One of the saddest statistics I know is that there are as many nurses in Canada not working as nurses as those who are. That's a waste of good education and care. The only way to recruit and retain people is to fix the workplace, and that matters to patients. As sociologist Pat Armstrong famously said, the conditions of work are the conditions of care. If you don't take care of workers, you're not going to get good health care. Now, of course, there are many, many other things that we can do to reform healthcare, but those are the big 5. And there will always be more to do. There's no perfect health system, and there never will be. We should always strive to do better. But we can't let perfect be the enemy of good. We can't sit back and wait until we have the perfect program. We have to act, we have to make mistakes, we have to learn from them. We shouldn't fear that at all. We should be going forward. Now, before I turn to the future, I want to tackle one other topic, and that is money. Because you can't talk about healthcare without talking about money. Canada is one of the biggest spenders on sickness care in the world. Last year, we spent $331 billion, roughly $8,500 per capita. About 42% of all spending in this province goes to our sickness care system. Countries that do a much better job of delivering care than we do, countries like Denmark and Netherlands spring to mind for me, they don't spend more money than we do. In fact, they spend considerably less, but they do spend more on social programs. They spend smarter. The worst part of Canada's spending is we get little value for money. We're obsessed with costs rather than results. We also have the least universal healthcare system in the world. And I want you to ponder those words for a second, because they're important. The least universal healthcare system in the world. So what do I mean by that? Well, as I mentioned before, our Medicare system covers 100% of hospital and physician care. It's done so since 1966. But there are many other health services that are required. But they're only covered in a piecemeal fashion. They're not covered by the Canada Health Act or any other legislation. We cover about half of prescription drug costs, 40% of home care and long-term care, 6% of dental care, and so on. It's hit and miss. Again, universal doesn't mean covered 100%. It means everything essential is covered. Now, the Canadian standard is that no one should be denied essential care because of an inability to pay. That's a great philosophy. It's one we should be proud of. The problem is we don't really live by it. Because if only doctors and hospital care are essential, then we're missing out on a lot of actually essential care. The result is, while our system's universal, it's inequitable. We have a public insurance program that covers everyone, but it covers everyone badly, unfortunately. When I go, I'm privileged in my work to travel to a lot of European, Nordic countries to see them in action. And what they do differently from us is they cover about 80 to 85% of all services publicly, from dental care through to hospital care, through to palliative care, the whole enchilada, covered a big portion publicly. And they pay higher taxes than us. That's a given. And then the balance has to be topped up with private insurance. But what's different is that they don't get worked up about private like the way we do in Canada, because they're clear about where the lines are drawn. Those countries are not better because they have an element of private care, as some people say. They're better because they're more equitable and they're more transparent. And they're clear about why they have private and why they have public. In Canada, there's no rhyme or reason to what's covered and what isn't, to the degree that it is. Is 100% of physician and hospital care essential at all times? I don't think so. I don't think anybody believes that. Conversely, why does an ambulance ride or a hearing aid, why are those not considered essential and worthy of public coverage in Canada? Why is the mouth not considered to be part of the body? Why is treatment of mental illness not covered, but treatment of physical illness is? Long-term care is another example of illogical public policy. Long-term care can cost anywhere from $2,000 to $15,000 a month. To qualify for government assistance, you essentially have to be indigent. That's very different from the rest of the health system. Instead of a paralyzing private bad, public good rhetoric that we bandy about, I think we need to answer a really fundamental question. What's covered by Medicare and what isn't? There's no question to me that we need private and public insurance, and we need private and public delivery of services. There's nothing wrong with that. But we have to regulate them properly. And what we should be debating is how to get the mix right, how to make sure everyone is covered equitably, not about just these words that are paralyzing. If you want to stop a debate in Canada, you just say, oh, that's privatization, and that's it. What we're doing, we're never going to solve the problems of Medicare by just doing more of the same. That's not innovation, it's stagnation. But the policy approach we have is one that I think was well described by Einstein. The definition of insanity, he said, is doing the same thing over and over again and expecting different results. And that's what we do in Canada. When something doesn't work, we do more of it. We spend more money, but it doesn't solve anything. So now I'm going to finally get around to talking about the future of Medicare. What will it look like, say, in another quarter century, in 2050, just to pick a round number at random? First of all, I want to say that demographics is not destiny. The aging population is not going to bankrupt Medicare. At least it shouldn't. That kind of rhetoric is not helpful. To me, the fact that we're living longer than ever is a triumph of medicine and science. We should be celebrating this every day. 85 is the new 65. In my work, I get to talk to a lot of older people, 90, 100-year-olds. What are they doing? They're out boating and playing pickleball, golfing. I have an uncle who's 93 now who tours with a Dixieland band. And he complains. He says, I don't have enough time to sail anymore. Too busy. That's the reality now. The vast majority of older people are healthy. Only 7% of people over 65 are in institutional care. 93% are living in the community, generally healthy. But we have to adapt to their needs. Most of them have a bunch of little chronic woes that they need taken care of so they can stay in the community. The job of policymakers is not to whine about an aging population. It's to adapt to the population's needs. Throwing up our hands isn't helpful. Now, there are two big trends in healthcare today that I think are going to shape the future: consumerism and technological disruption. Perhaps it's more accurate to say that what's coming is a revolution in healthcare. But I'm not prone to hyperbole and I'm not prone to predictions. But I think where you sit especially, you know this better than others, I think there truly is a revolution coming. And not a moment too soon, I should say. So let me start with the technology piece of the puzzle. I'll wade into these dangerous waters that you know much better than I. Now, during COVID, not everything was bad. There were some silver linings. One of them was that we saw a dramatic rise in the use of telemedicine. We made about 20 years progress overnight. Prior to the pandemic, about 1% of medical visits were virtual. During the pandemic, that number jumped to 50% on average. In some institutions, it was as high as 90%. People like dealing with minor health problems on the phone or online. We knew that before, but they actually got the chance to do it. They can avoid long drives, they can avoid long waits, and they can avoid parking costs. Of all the mail I get, and I get a lot of mail, number one is parking. Everybody hates paying for parking. I think people forego heart transplants because they don't want to pay parking, to be honest. It really sticks in people's craw. But, this virtual care is not only good for patients, but it's efficient for practitioners as well. It's a win-win. Unfortunately, what happened now that we've declared COVID over, we've gone back to our evil ways. Most provinces have stopped funding virtual care the way they did during the pandemic. And how did we bring about this revolution? We had said one thing. We said, we're going to pay doctors the same amount of money to see someone virtually as in person. Dramatically, overnight, it was suddenly possible. Imagine that. Doctors said for years they couldn't do it. Pays the same, they can do it. But now we've rolled it back. Ontario has gone back to its old billing codes. So you get a fraction of your payment if you see people online. So shockingly, people now all have to go into the office again. It's crazy how we don't learn. Now the public's having none of this. Online physician services like Maple are booming. People are paying out of pocket for convenience. We're seeing an explosion of clinics in places like Walmart and Superstore, where they have free parking. Recently, I visited a clinic in a Walmart in suburban Vancouver. Clients checked in, they got a buzzer, just like you do when you go to, Milestones or something. We'll buzz you when your table's ready. So they'll buzz you when your doctor's ready and you can go shopping at Walmart. So multitasking, people like that. One of the patients I spoke to that day went for a vasectomy. On his way out, he bought some Tylenol and a bag of frozen peas at Walmart. So one-stop shopping. But that's the future. The future is consumers want convenience, and they'll pay for it. And what's coming next is even more impressive. Self-driving vehicles and drones that will deliver everything from drugs to medical equipment between institutions and even to your home. On the weekend, I was in Ottawa at a conference, and I watched a demonstration of a drone that carries medical tests between hospitals. So it's a hospital with 3 sites. Instead of having 3 labs, they have one, and the drone brings all the test tubes from one place to the other. Zoom, roof to roof, very efficient. That's reality today. There are mobile labs that are being tested that can travel to a patient's home and do a full workup. Take your blood pressure, oxygen saturation, blood draws, and everything. A little robotic machine that comes up, just like Domino's Pizza is delivering with driverless cars. Similar thing, except you get a needle in your arm instead of a pizza. Some of this technology will also be on your wearables and your phones. We have phones now that can do ultrasounds. If you read Eric Topol, he's sort of the health technology guru. He talked about saving the life of a man on a plane. He did an ultrasound of his heart. He's a cardiologist on a plane and helped him out thanks to his phone. Now, healthcare is very labor intensive. Technology is going to replace some people, and that gets some of us worked up, but it's not all bad news, especially given the severe staff shortage that we have. It's going to help fill some of that gap that's going to grow as the population ages. It should also free up some workers from routine tasks, allow them to actually spend time with people. That's what gets me excited about technology. You can actually be able to sit down and talk to people instead of spending all your time on a computer entering data. I visited a nursing home in Japan where robots did the bulk of the work. They monitored patients, they delivered food, they could even help with tasks like toileting and bathing, changing continence pads. There were also, in that home, robotic dogs and cats to help ease the loneliness of elderly people. And if people are wondering, that seemed kind of creepy, right? A little robot. But people love them as much as a real dog, but they didn't have to take them out for a walk. this stuff it makes a difference, especially to people with dementia. Now, unfortunately, Canada's a laggard on technology. We still struggle with some of the most basic technological things like electronic health records. We have a serious lack of interoperability. Our systems don't talk to each other. Down the street, you can go to University Avenue. The journalists, we call it Pill Hill, with its 5 hospitals. I sat in a hospital one day in someone's office, and the next hospital you could literally reach out the window and touch it. And those 2 hospitals couldn't communicate electronically. This researcher said, the easiest way to talk to my colleague next door, 2 cans and a string, because we don't have compatible systems in any way. This is crazy stuff. This just shouldn't be happening, especially that it's all paid for with public dollars. Interoperability should be a starting point. Right now, physicians and nurses spend a lot of time inputting information from patient conversations. I recently read a study that said for every hour a nurse or doctor spends with a patient, they spend 2 hours on data entry. But transcription software and AI technology, similar to ChatGPT, is evolving so quickly that key points of conversation can now be summarized into medical records automatically. I saw a demonstration of something called, I don't want to promote any particular product because I don't know them, but this was called AI Scribe. And just a doctor sits with a patient, not staring at a screen, just talking like that. And at the end of their 7-minute visit, out came a summary. Here's your prescription. Here's your next appointment. It had some prompts for the doctor. Oh, you forgot to ask about A. You should ask about that. So that's reality today. That's not tomorrow. That's exciting stuff. I want doctors to be there saying, I feel for you. How's your family doing? Not doing this all the time. That's what technology to me should do, is free up people to care. But the other thing it's freeing care providers of mundane tasks. That's really, and allowing them to care for people is what we should want of technology. But we have to remember too that this is not just about technology. It's largely about policy choices made by humans. And we don't have a great record of making right choices. We often blame technology for decisions that are made by governments and corporations. And that just lets us off the hook. All this stuff that's coming, we have to decide if we're going to use it and how. And these are decisions that have to be made, and smartly. Data is increasingly the most precious resource we have in healthcare. It's the new gold, or maybe platinum, I don't know. The day isn't far off when every child will have their genome decoded at birth, and it'll be downloaded on their phone. This is actually happening in pilot projects. I read about one in Massachusetts the other day. Your whole genome right there on your iPhone. Now, this has some benefits. In this Massachusetts study, it allowed for the early detection of rare disorders. It prevented some serious illness and even death by doing this. It'll provide information on whether a person's predisposed to conditions like heart disease, diabetes, and dementia. Hopefully, allow preventive measures to be taken. Although there's some ethics here, should we be telling people about things we can do nothing about? As someone who comes from a family with early dementia, I struggle with that one. Do I want to know if I have that gene, if I can do nothing about it? Personally, no, I don't. I just want to goof around for a while longer. As important as genomics is going to be socionomics, the analysis of the impact of your socioeconomic environment on your health. Hopefully it'll help us embrace prevention a little more, and help us recognize the benefits of investing in education and housing and income supports. Shifting resources upstream doesn't have to be about compassion. It'd be nice if we were compassionate, but we can do a dry cost-benefit analysis and make the case for it. Data can help us move away from sickness care to a healthcare system. So a couple of minutes left, so let me talk about what I promised in the question mark, artificial intelligence. As you know, it's in its infancy, but it really has the potential to change medicine and healthcare fundamentally. And I don't have to tell you this in this audience. You're at the cutting edge of this. For some of you, AI is already part of your daily practice, and it's going to grow, I was going to say every month, but probably every day. AI allows the continuous collection of data and can be used in a constant feedback loop to improve care, if we do it right. The reality today is that a lot of drugs only work half the time. We don't really know why. Similarly, surgery outcomes can vary dramatically between patients. We don't know why. Big data can help us parse out those differences and learn from them. We know that half the things we do in medicine are not helpful. Many of them are harmful. But again, we don't always know why or which ones. Data can help us sort that out. Again, that's what makes it exciting. There are already good algorithms out there that can predict if you're going to have low blood sugar or a heart attack or sepsis. They allow early intervention. They save lives. And this sort of data analysis is going to become more commonplace and spread into many areas. The smartwatch that probably everyone in this room is wearing is going to get a lot smarter and quickly. But of course, there are concerns. This is not all wonderful, sweetness and light. Information is great, but you have to act on it. It has to be actionable to be useful. It isn't always. Sometimes we do data collection for the sake of data collection. And we don't always collect the right data. One of the things I've had a bee in my bonnet about for decades is about the lack of race-based data in Canada. This really harms us, especially in a multicultural country like this. It's a perfect place we should have this information and we should use it thoughtfully, but we don't. We pretend we're blind and all we are doing are hurting patients. As I said before, somebody has to decide how to use technology. We can't allow the machines to set the medical priorities. Humans have to do that. Privacy is going to be a big challenge, I think. In the era of quantum mathematics, encryption is going to be essentially impossible. So we're going to have to figure out a new approach to privacy, especially of medical records. You've all read stories about ChatGPT being, how should I put it, a little glitchy at times. It makes stuff up. It lacks morals. We can't expect a machine to have morals, but we have to recognize that shortcoming. And I'm thinking here of this disturbing story I read about a teenager who wanted to kill himself, and AI actually encouraged him to do so. They made a rational analysis. Based on what you're telling me, yeah, you probably should be dead, kid. That's not what you want to be telling a teen in distress. The AI tool even pointed to some of the most effective methods. Thankfully, that child didn't die. This was being monitored, but it sends up some warning signs. AI parses incredible volumes of data and summarizes it. It's sort of a cut and paste program on steroids. But there can be a garbage in, garbage out problem. And there's a lot of garbage research. We can't forget that. AI can also entrench bias, can be racist. That's because most research is done in Western countries on white people. It may detect sepsis well in Caucasians, but not in Hispanics. I saw that in a story about pediatric sepsis. The Hispanic kids had worse outcomes by far. We'll tell physicians not to prescribe painkillers to black people because of the research biases that exist. The solution to this is not to stop using AI, it's to have better data and to be aware of these limitations. And again, I come back to that issue of race-based data. How all the race-based data we have is out of the US, which is where life is a little bit different. We should do it here. Machines are trained to find patterns in large data sets, but they don't know how to make sound judgments. We still need real intelligence to do that, not artificial. But I guess my biggest question about AI is how quickly and smartly we can incorporate it into clinical practice. As it stands, and the research shows this, it takes an average of 17 years for health innovations to move from clinical trials to guidelines to practice. That's a long time. Are we going to do better and faster with AI? Are we just inherently resistant to change? And, some fancy new AI offerings, are they going to be able to break through that cultural barrier? I'm not sure. Will it be funded properly? We're very reluctant to fund new technologies. And all these technological advances I've mentioned, and many more of them, all of these are driving personalized medicine. Right now we have a very industrial model of medicine and healthcare. We have guidelines for treating people generally, and that's what we do to everyone. But increasingly, medicine is going to be about an N of 1. The data is going to be specific to you, to your genome. This is going to be a massive challenge for Medicare. Medicare is an insurance program for the masses. Health insurance for individuals is a very different beast. How are we going to adapt? I'm not sure we can. An equally important change coming to healthcare is the consumer revolution, and these are tied together. In Canada, we talk a good game about patient and family-centered care, but it's mostly tokenism. Increasingly, patients and their families are demanding better. They're demanding a voice. And having more information at their fingertips is going to make a difference. It's going to break down this paternalistic structure of medicine that we've had since the 18th century. It's going to help free people up. You know, patients have to be an integral part of the healthcare team, not just passive recipients of care, especially in the era of personalized medicine. As a result, two fundamental things are going to have to change. Right now, healthcare delivery revolves around buildings, hospitals, clinics, nursing homes, places people go to queue up for services. In the era of digitalized, personalized medicine, healthcare is going to be built around people. Bring the care to them, not forcing them to go to the care. The work-at-home revolution is going to fuel a care-at-home revolution. In fact, care can increasingly happen anywhere. You know, I mentioned these little vehicles that come to your home and come to your workplace, to your school. My own doctor sent a note to her patients recently to remind them that virtual medical visits probably shouldn't be done on the city bus or at Starbucks, because that's what was happening. She had to remind them, you know, everybody shouldn't be hearing about your genital warts at Starbucks. But she also admitted she has to adapt, because that didn't seem to bother some people. With the aging of the population, shifting care to the community is especially important. We can't just stick a whole cadre of older people in nursing homes and long-term care homes as they get old. It's costly, and it's a terrible way to live. We have to keep them in the community, and technology can help. We need to invest in supportive housing, making cities more age-friendly, and so on. The fundamental change coming is that provision of care will be continuous, not episodic. And we have to stop treating patients as disembodied constellation of body parts and conditions and start treating them as a whole. It's almost going back to the centuries ago where you actually looked at a person, not just because we didn't have all these fancy things to look in their body. An actual person whose environment is as important as their medication. You know, we have to reinvent the patient experience for this new era. And paradoxically, in this age of hyper-specialization of new technologies, the generalist is going to become far more important. They're going to be a navigator and someone who brings together a bunch of information and figures it out, how it fits to the whole person. So I come back to what I said at the outset. Every patient must have a medical home. It's becoming more important than ever. The primary care provider, whether it's a family physician, a nurse practitioner, it might be a robot at some point, who knows? They're going to have to be the hub. They're going to have to be the navigator, the repository of information to sort it all out. That's why primary care always has been, and I think always will be, the foundation of health, no matter how technologically advanced it is. What I'd like to see, if I saw one political revolutionary idea implemented for me, it was that every government in this country would make a promise that every Canadian is going to have a family doctor. This was in a report of the Public Policy Forum recently. They said every Canadian should have ready access to a primary care provider within a 30-minute drive of where they work or live. Every single jurisdiction in this country should adopt that. That's the starting point for fixing healthcare. And I'm not talking about half-assed promises during an election, a chicken in every pot thing. Not that. A real commitment to do it, to have family doctors. We have a dramatic shortage of family doctors, but we have to remember that half of the family doctors we graduate in Canada don't practice family medicine. There's a solution right at hand there. These are little things that can be done. I'd like to use the analogy of public school. Imagine if we said to parents, sorry, we don't have room in school for 6.5 million Canadian kids. You're going to have to come back next year. Would people tolerate that? We should no more tolerate being told that, sorry, we don't have doctors for everyone. Healthcare is essential as education, and both should be provided and fully provided to everyone. As I stated earlier, the philosophy of Medicare is very simple. No one should be denied essential care because of an inability to pay. That, in many ways, is the embodiment of Canadian values, that we don't just value individual rights, but we feel we have a collective responsibility to each other. We have to give those policies life in our public policies. So I hope I've driven home one key point today. Canada's health system is struggling, but it's fixable. There's help on the way. We don't lack knowledge. We don't lack expertise. We don't lack money to implement health reform. We just need to roll up our sleeves and get to it. This isn't a time for nihilism or cynicism. You know, after 3 years of pandemic living, people want some hope. Technology offers a part of that hope, but not all of it. I'm not really hopeful that Medicare can be fixed, but it can be reinvented. You know, Medicare is how we as Canadians give life to our values. As we did after the Second World War, we have to again create a new world, a new way of delivering healthcare. I'm also adamant that we not only have the ability, but the obligation to fix Medicare, to create a health system adapted to the demographic, economic, and technological realities of today. We owe that to ourselves, we owe it to our children, and to our grandchildren. So I'm going to stop there. Welcome any comments or questions that you have. But thank you again for the I see there's a guy with a mic there. It's just because it is being recorded, so I'll make sure you ask your questions. Someone right in front here.
Sure. Yeah, go ahead.
So a bit more.
It's one point that you mentioned is that half of the drugs that we use don't work, and we don't know why. And during that statement, I actually made a very interesting connection to something that I learned in pharmacy school. So in third year of pharmacy school, I took an elective called pharmacogenetics. And in pharmacogenetics, we had some early researchers come in with early results of their trials. And in those trials, they had patients who had tried a number of different antidepressants, first line, second line, third line, and nothing seemed to work. But then they got pharmacogenetic testing, and then they were able to find that the CYP enzymes in their liver were actually, because of their genetic makeup, some CYP enzymes actually did a lower rate of clearing than other CYP enzymes. And so the pharmacists at that time chose basically drugs that will be best for the CYP enzymes. And then the patients experience rapid improvement and alleviation of their symptoms. And so one of my hypotheses is that perhaps the reason that those drugs are not working is because of the pharmacogenetic makeup of those patients. And if we were able to have more pharmacogenetic testing, then we would be able to basically give patients a better care.
Yep, it's definitely a solution, but we have limited pharmacogenetic information. We have it for some drugs, but we need the basic research to figure that out. Once you have the information, it's easy to implement it, but it's having the basic research. And I didn't mention that in my talk, but we have to invest there too. We have to get the basics. If we're going to use data, we have to have the data to back it up. So thanks.
Maybe we'll do one more question.
I really want people to hear me. That was a great talk. So actually, Mohammed and I just came back from what was notionally called an AI conference, AI in medicine conference, but it was more an AI in medicine trade show, and had a bunch of companies pitching things. And one of the things I noticed is they had a whole bunch of interesting models. One was essentially a natural language chatbot as the interface into your primary care. Super interesting. I mean, we love to talk. But every single time, towards the end, they said, and because of this new technology, we can now cram in another 5 to 10 appointments for this primary doctor every single time. And I really don't like the idea of that, because it's not moving us towards that, doctor who actually knows you. So I was just wondering about your perspective of that and maybe
Yeah,
anything.
so it comes back to what I said. That's not a problem of technology. That's a problem of policy, right? It's how we use the technology. So yeah, some doctors can cram in 5 more, but some should be cramming in or uncramming 5 others, right? So we have to find the right balance. So technology can help, but we have to use it wisely. So yeah, and I think, I think this trade show was in the US and where it's particularly about money, so we have to be careful. But there's other ways of getting more bang for our buck out of doctors. I was just in Winnipeg where they have a program where the government will pay to hire a physician assistant if you take on 500 extra patients. And that physician assistant can do it. So that's a way of expanding the availability of doctors without burdening them further. It's not more work for the doctor, it's actually less, and they get to do more doctoring and less of the physician assistant weighs people, does their blood pressure. Our health workers do a lot of stuff that other people can do. We don't provide them with enough support.
Thank you. I want to take this opportunity to really thank André. He has this incredible talent of taking such a broad view on things, but being so insightful and going broad and deep at the same time. So thank you so much, André. This is just a small